physician health program and has held the position since then. He completed a Master's of Education degree at Simon Fraser University in 2013. His research interests are in the field of organizational interventions to facilitate return to work and reduce conflict in the workplace. In particular, his focus has been on the effect of common mental health issues on those diagnosed and on their colleagues. Ladies and gentlemen, please help me welcome Dr. Andrew Clarke.
Okay, thank you so much, Aaron. So you're not having a hallucination. I am actually asking you, instead of putting away your phone, to take your phone out because we're going to use it today, if possible, and that applies equally to the people who are online. You should be able to, if you're online, you should be able to participate in this poll. So the people in the room and the people online, please take out your phone and send a text message to the number 37607. And the message that you send should be my name, Andrew Clarke, 459. And you don't have to make the E red, but I did that because it's one of the curses of having a common name that has silent letters. Everybody thinks they know how to spell your name, but then they make a mistake and leave out silent E and stuff like that. So it's Andrew Clarke with an E, 459. And if all that goes well, you should get a response similar to the picture that you see on the right that says, you have joined the poll. And I'm going to put this slide up again a couple of times because sometimes it takes a minute or two for everybody's joining of the poll to clear and whatnot. So while you're all busy doing that, I'm going to tell you that I have nothing to disclose really. I'm an employee of the Physician Health Program, which is a program that's half funded by the Ministry of Health, half funded by the doctors of BC. I'm a full-time salaried employee of the doctors of BC, and I don't get any incentive for work volume. So if as a result of this, all of you call the program and give us lots more work, it won't make any difference to me. I'll be overjoyed. No, I don't think there's that many positions in the audience, so I don't expect exceptions to industry-sponsored research. So if, in case you missed it, here's the phone number, the number to send a text message to. Hopefully you'll get a response confirming that you've joined the poll, and it may take a minute or two. So this is I'm calling this talk Striving Towards Psychological Safety, Re-Examining the Discourse of disruptive behavior. And so here's what I hope to achieve. I'd like, at the end of this talk, I hope that you'll be able to describe different ways I concept of psychological safety.
Can you hear him?
Now it's good?
Yeah.
Okay. All right. So sorry about that. Okay, let's go back to this. So we want you to be able to describe two different ways to define psychological safety and be aware of the consequences of using those. That would probably be my most important objective. And so that's where the psychological safety comes from. I'd also like to raise the topic of how kind of goal framing can undermine the achievement of a psychologically safe workplace. And that's sort of the toward, the punchline there. And then describe different paradigms of improvement and how these can affect goal achievement. And I guess those are all very sort of technical ways of describing what I hope to get done in this talk. But I think more importantly, what I would like to raise with you is the issue of the overall importance of this kind of stuff. And to put that in context, or to make it a little bit more generalizable, I think in the field of population and public health and occupational health in particular, what we sometimes perceive our job to be is to put together statistics and make a case for why a certain policy should be enacted as a result of the data that support it. And then sometimes we end up wondering why those policies either don't get enacted, people ignore our plea based on data, or they, what's even more mystifying sometimes, and this is more relevant to this case, is we do something to try to implement a policy based on data that happens, and what we try is not effective. And then we have sort of a real mystery to solve about why does this not seem to be working? And why are we not achieving the results that we think we should be achieving as a result of spending so much effort on something that is so important? And I would argue that this is why we have to pay attention to things like definitions and goal framing and improvement paradigms. Okay, so one last time, for those of you who just came in, please retrieve your phone and send a text to 37607. The message that you send is Andrew Clarke with an E, 459. You should get a confirmation that you joined the poll, and it may take a minute or two for you to get that confirmation. Okay, so I'm going to talk first about this idea of choosing a definition of psychological safety that we can hang our hats on. And the one that I'm going to start with is this one, which is in the Canadian Standards Association document. This is where it comes from, the Psychological Health and Safety in the Workplace, Prevention, Promotion, and Guidance to Stage Implementation. The 2013 document. And this is the definition that they propose for a psychologically healthy and safe workplace. So you see, it's not exactly defining psychological safety, it's defining a psychologically healthy and safe workplace. And they say that a psychologically healthy and safe workplace is one that actively works to prevent harm to worker psychological health, including in negligent, reckless, or intentional ways, and promotes psychological well-being. So it is in the room, hands up people who are familiar with this definition document, a couple of people. Okay, so you may not have read this document or looked at it, and you may be wondering, well, why is he picking this one to talk about first? And the reason that I'm doing that is because the 2014 collective agreement with the BC Nurses Union and the healthcare employers of BC actually mandates the implementation of this standard in all healthcare workplaces in British Columbia. So this is a very relevant document. This is something that people are trying to implement right now in all healthcare workplaces in BC. And that's why I think it's something that if we're learning about occupational health, and in particular occupational psychological health in British Columbia, we should know what's going on here. And so this is a little bit of a peek into the document, and I'm showing you this page in particular. You probably can't read it, but I'm going to, for the benefit of those who can't read it, but it basically organization shall develop and implement and maintain a documented risk mitigation process that includes hazard identification, elimination of those hazards that can be eliminated, assessment for level of risk for hazards that cannot be eliminated, et cetera, et cetera. So that should sound familiar to you if you're in the field of occupational health and safety, because that's basically the standard paradigm of what we call the hierarchy of control. So in industrial hygiene practice, what we try to do is we try to identify something that might be hazardous. We rely on data that are produced in studies that is a hazard. We look at those hazards and we say, well, once we recognize that something is hazardous in the workplace, we should try to remove it if possible. We should try to substitute it. There's a chemical that you have hazardous in the workplace. There's another chemical that people are doing. Right? very obvious. So replace it and move it. Then we go to engineering controls, where we try to build a wall around the hazardous process, so that the employees or the workers who are in the vicinity don't come into contact with that hazard. And then at the last resort, what we do is we can't do any of that. We actually try to protect the workers from the hazard. So we use personal protection. So I'm hoping that this is familiar to all of you. And it seems like if you're going to build, one of the ways that we do things when we enter a new campus, we have something like this that seems to be working quite well. And then somebody comes along and says, well, what about psychological hazards? It's natural for us to say, well, let's just apply this hierarchy of control to psychological hazards. And I guess what I want to kind of ask is it really fair to do that? So how generalizable is the hierarchy of control? This is where I want you to get ready to participate in the poll. So haul out your phones. Here's the statement that I'm asking you whether or not you agree with. The hierarchy of controls approach should work just as well for psychological hazards as it has for physical, chemical, and environmental hazards. So here's what should happen is when I go to the next slide, it should open up a poll and we'll see what everybody's results are. So what you do now is you text the number to this thing. Oh, I can see it's happening. This is actually a time for joyous celebration. Honestly, oh my gosh, I try to do this a lot because I do think it's actually quite captivating for audiences. But it always seems to work out that whenever there's a screen share, that this thing ends up half off the screen, and I'm the only one who can see it. So I feel really, I want to thank your team members who helped me get it all set up. So that's interesting. This is this is the best possible poll result when we have kind of a bimodal distribution. I love this. So some people really don't care, they're not sure, but then there is actually a split, sort of equal people. Split because some people disagree with that. Some people think that, let's go for it. And obviously, the people who wrote the CSA standard, who are, kind of an august group of practitioners in the field, they would agree. They wouldn't have done it. They wouldn't have spent all that money doing it if they didn't think that it would agree. Yeah. Oh, it goes away. Okay, yeah. All right, thank you. Thank you for reining me in. So now I want to, I didn't present you with statistics about this, so I'm actually going to do the hand-waving argument and just ask you to tell me what you think is behind the long-term decline in worker injury rates that has occurred since the 1990s. So we've been in a long-term secular trend of worker injury rates going down since sort of the mid-90s. In the 80s, there was kind of a crisis. They were going up, 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 up. Workers' compensation systems were kind of under threat for being insolvent. And then things turned around and we started to see worker injury rates going down. So here's the choices. Did that happen because there was a rigorous application of good safety and hygiene practices? Or was it the rise in popularity of total quality management? Was it some other factor that I didn't name? Or do you think this is just a really dumb question? Okay, so here we go. Oh, it's activated. Okay, good. Well, I'm pleased that no one thinks it's a dumb question. Yeah, that's actually good. Okay, so most people seem to think it's a rigorous application of safety and hygiene practices. Some people think it's something else. Total quality management is not too popular, but people think it's a reasonable question to ask. Okay. Still people weighing in or changing their results. Okay, I'm going to lock it there. All right. Okay, well, I'm going to go on. And this is where I'm pleased to see young people in the audience because this is going to be a little bit of a history lesson. Which probably people, if you're my age, this will be boring for you, so you can tune out. But if you're not, if you're younger, which is almost everybody, you can pay attention to this. So this I want to go back even further than this, the 80s and 90s. Back 100 years, or even further to 150 years ago with the Industrial Revolution, where basically there was all these expanded needs of production, and workers were really considered expendable. And in some ways, they considered themselves expendable because they were sort of coming off of subsistence farming and going into factories. And there was a notion that workers in general had to be sacrificed in order to make a profit. And then you see the rise of the trade union movement and other things that rise up in opposition to that. And then sort of the whole big picture history of occupational health and safety arose, at some point in the 20th century. People can disagree about when, but kind of saying, it's not okay to consider your workers expendable, and it's not okay to sacrifice their health in pursuit of profit. And so things started to change, and that was sort of more or less the genesis of the occupational health and safety movement, is we should start counting what kinds of harms our work environment is doing to workers in order to make a case to treat them better. And until the 80s, we were kind of marginally successful about that. We did some things. We recognized asbestos. We kind of took it out of most workplaces, and we used this kind of hazard elimination philosophy to get rid of a lot of things that were negatively affecting workers' health. But we still had this idea in the 80s, and I know because I was there, that worker health and profitability were somewhat in tension. They were not on the same side. And there was objections to implementing worker health measures because they cost so much. And organizations considered them an expense, not an investment. And then along came this, and I won't go into the whole history of the total quality movement, but it basically arose mostly in Japan, and it was something that was kind of concocted by the U.S. military. The Japanese heard about it, made it way better, and then it came back on shore to North America. And this idea that customers don't want necessarily cheap stuff, they want good stuff. And so product quality became a real path to profitability. And the business literature is just full of instances of people kind of saying, hey, General Motors, wake up, people don't want your crappy cars, make them better. And so that really, really caught on, and what came to be sort of accepted as the truth was that product quality and worker safety were no longer on different sides of the fence. They were on the same side of the fence, and they were both just instances of how a production process could lose control. So when you lose control of your production process, you make crappy stuff and you hurt your workers. So you better get whatever your production process is, whether it's manufacturing or whether it's service provision, you better get control of it, and because it's going to do both of these things simultaneously. And we did actually start to see that, right? So that's and that arose and really caught on. If you look at some of the dates of these things, this one that said merging strategic safety, health, and environment into total quality management, that was an article from 1995. So around the mid-90s, there was enough history that academic writers could write about it and talk about how this was happening. Right? So that's when it kind of happened. And the key components of total quality management were these two: defect elimination. So you more or less count all of your defects, and this is how worker injuries and products going out of spec are both considered defects. So we count all of our defects up, we document our processes very carefully, we measure them, then we get together and we brainstorm about how we could reduce the defects, like how could we have fewer injured workers, how could we have fewer holes in our whatever, canvases or whatever. And then we come up with the solution, we agree on the solution, we try it out, and we see whether that makes a measurable difference in our product quality or defects. And when you look at how this kind of got implemented in North American workplaces and workplaces really around the world, there's two key elements that the textbooks all tell you about this. You can't just focus on the technical thing about putting up charts and ticking when there's a defect. You do need to work on empowering workers, like this idea of the stop the line. Anyone has the power to stop the line if something's going out of spec or becoming unsafe. So workers need to be empowered. you have to pay attention to how you implement changes. So it's not just, you can't just walk in and say, okay, everything's going to be different now, right? So paying attention to people's psychological ability to accept change is important, and facilitating how team members relate to each other is a real key feature of this, right? So there's a lot of training. 150 years ago, a supervisor was somebody who came around and like actually physically disciplined you and rapped you on the knuckles if you were not doing things the right way. And that, of course, just completely transformed into, here's how we have to actually all be on the same page. And my role as a team leader is one of more of a servant who is trying to facilitate a team process. So in other words, there were technical aspects of TQM that were important, and then there were social aspects of TQM that were important. So there's the history lesson. So then along comes, so the mid-90s, everybody's onto TQM, and then this happens in healthcare. So somebody, the Institute of Medicine, who is a group representing doctors in the United States, kind of said, gee, you know what? This TQM philosophy, we should implement that in healthcare, because our product quality is terrible. We are killing 98,000 patients a year from avoidable things, right? So here's an example of an occupational population health approach saying, let's count up all the cases in which we are having a really bad outcome for, in this case, it's not so much our workers, it's our patients. They are dying because we're goofing up. So we need to start counting these defects and really turning our attention towards fixing this problem. So, of course, people immediately walked out and said, well, look at how General Motors did it. Look at how the aviation industry works. You know, the aviation industry is one of the only ones that really achieves the Six Sigma philosophy, where they're out 6 standard deviations from where you would expect, and they have so few defects, right? Like so few plane crashes. So there was a big popularity movement of, let's take everything that we've learned in aviation and try to apply it to healthcare. And so this is an article from 2004 about the initial results of that. What happened when we tried to apply that philosophy? So Dave Musson is actually a Canadian physician who at the time was studying organizational psychology with Robert Helmreich at the University of Texas. And now I think he's the dean of the Northern Ontario School of Medicine. But at this time he was working on his PhD or he had just received it, or this was his thesis research of let's look at what happens when you take aviation concepts and try to apply them in healthcare. And what they found was that in healthcare we were really good at adopting the technical standards, but we just left out all the social stuff. We didn't bother with the worker empowerment or anything like that. And even in cases where we thought that we should do it, we recognized, oh, we should empower all our workers to do all the stuff. And so we adopted this. This is really what this article is specifically about, is they canned all the social aspects and called them crew resource management or team training or crew resource management. And even then, so an example of a crew resource management practice is in aviation, all the people on your flight that you're going to get on the plane, the whole crew, including the pilots and the flight attendants, they all get together before the flight and have a huddle, right? And they talk about, flight's going to go here, it's going to do this, blah, blah, blah. Here's all the technical aspects. This is a flight that's going from Vancouver to Winnipeg. It's going to climb to 30-some feet. So they rehearse the whole thing. And part of that pre-flight huddle is them talking about things that they have brought to the workplace that might affect their performance on the job today. So it's like, well, my 2-year-old son's home with pink eye, and I'm constantly thinking about him, and and being a bad dad by being here, and leaving my spouse to take care of the situation. That might affect what's going on for me today. So I want you all to cover my back. So it's that aspect that never ever shows up when these things are applied in healthcare. So we've tried to adopt this practice in healthcare by having things like pre-procedure checklists where the whole OR team gets together and has a huddle. But those aspects of, here's what's going on for me internally today, I'm going to share this with you in order to protect our patient, that never ever happens. So we have a real resistance in healthcare to adopting some of the social practices that actually help us. And So 2 decades later, we really aren't much further ahead. This is an example of how people did really good statistical work counting up the number of important outcomes that affected our patients. And we tried really hard to do stuff, but we didn't get anywhere. And this is an article kind of summarizing how, in some, the frequency of preventable harm remains high, and new scientific and policy approaches to address both prior and emerging risk areas are imperative. This is from late 2018. So this is when, they're kind of saying, gee, we've kind of made some headway, but really not nearly enough. So what's up with that? So here's what I would propose. This is an article from, again, it's 2003, so it's really contemporaneous with the Lesson and Helmreich article. But this is Amy Edmondson. Anybody heard of Amy Edmondson? Okay, so she's a psychologist at Harvard Business School. And she's really done a lot. This is sort of some of her earlier work where she was looking at how organizational and psychological dynamics in hospitals prevent them from learning in these situations. So learning from failure. And so this is kind of a summary of this article. So she noticed then this was ethnographic research. She followed nurses around for months and months and months in a variety of different supposedly great hospitals. Like these were hospitals that were trying really, really hard to do good. And they were selected for being the best hospitals around. So it was a purposive sample. And she noticed that when a worker in a hospital faces missing materials or information, what the ideal behavior is that worker would just adjust to the shortcomings without notifying anyone. So try to make the error as invisible as possible. But in other organizations that are able to learn from failure, you remedy the immediate situation, but you also let everybody know that a failure or a near miss has been experienced. And when you notice somebody else's error, your job in a hospital is just to seemingly correct for it. Do not risk a confrontation by informing the other person. Okay? Whereas in learning organizations, you will create learning by informing other people about your mistakes. But if you do that in a hospital, you're going to be labeled as a troublemaker. And if you make a mistake in a hospital, you cover it up as soon as you discover it, because you want people to trust you as a reliable person, as a healthcare practitioner. Whereas in a learning organization, you would immediately disclose the error or the near miss to others so that they can learn from your mistakes. Don't make the mistake I did. Here's what happened. And then when you have an opportunity for system improvement in a hospital, you just demonstrate commitment to doing things the way they've always been done. That's not the way we do things around here. So you try to shut down things for change, because if you don't, you're going to be labeled as a disruptive questioner. Why are we doing this other way? This would be way better. Okay, so I want to just now pause and kind of connect the dots. So what's holding up quality improvement in hospitals? For quality to improve, workers have to advocate for change. They have to feel like they are free to advocate for change. And the healthcare workplace values ideal workers, the ideal worker paradigm, not the system changers. And in fact, we've evolved this whole discourse of disruptive behavior, in super big scare quotes, to label people who are in the third column, the people who would create organizational learning according to Edmondson's definitions. They're labeled as disruptive. And so there's a whole, if you do a Google Scholar search for disruptive behavior, you'll find most of it is attached to physicians, because physicians tend to be the ones who feel like they're in a position, enough of a position of power to advocate for change, and then they're immediately labeled as disruptive. And so what I guess the pinnacle, the crux of my argument is that that's who the psychological hazards are. Psychological hazards are not a what, they're a who. So if you're looking for a psychologically healthy and safe workplace, it's not like you can go around and apply, a NIOSH method of measuring asbestos and stuff like that. 90% of it or more is subjective. The psychological hazards in the workplace are the other people in your workplace. So if you're going to eliminate hazards, you're eliminating people. That's what you're talking about. So my argument to you would be that control hierarchy really stops generalizability at the sort of biological realm. It does not extend to, or there are perils to extending the control hierarchy model into the functioning of our brain. And this particular brain diagram is sort of to illustrate the fast or limbic system processing versus cortical or slow cognitive processing, because another whole talk is how that's connected, but I won't go into it right now. So if we were to say, what are these new scientific and policy approaches that these authors are calling for in 2018, what would they look like? What would those new scientific and policy approaches look like? Well, one would be that we could define things differently. So we could choose a different way to define psychological safety from the one that is in the CSA standard. And then a second thing would be to frame it as an approach goal, not an avoidance goal. And I'm going to talk about why that might be a little bit important. And then try out different paradigms of improvement. So here's Amy, this is a picture of Amy Edmondson. And so here's what her definition of psychological safety is: the degree to which people view the environment as conducive to interpersonally risky behaviors like speaking up or asking for help. And this is actually a very nice construct, because you can see that this actually it's an operational definition that you can get at with self-report. You can just say, how safe do you think it is to speak up or ask for help? And you've essentially measured psychological safety, according to her definition. And she has, I think, about 7,000 citations in the, if you look her up on Google Scholar, you get about 7,000 hits. She's a very prolific author, so she has used this definition in a lot of contexts, and she can back up this claim about why this is important. And this was an issue that the doctors of BC, where I work, thought was really important in response to the implementation of this psychological health and safety standard of CSA in all healthcare workplaces in BC. And so this policy paper, which you can download from the Doctors of BC website, is an attempt to say, we think you're kind of making a mistake here, that you probably, no, don't get us wrong, we support a psychologically healthy and safe workplace, but we want it to be healthy and safe for everyone. And we think that by pursuing this defect elimination and hazard elimination model, you're actually working against yourself, because you're making it impossible for people to speak up for change. So coming close to the end now, I do want to leave time for questions, but I want to, I think it would be a diversion into uncharted territory if I explain to you all of the literature that is out there about approach versus avoidance goals. So I just put up a bunch of references to say that the idea of goal framing and how that affects our own psychological health is actually quite important and is well described. So if somebody gives us a goal to strive towards, we naturally, the process of striving towards that goal tends to increase our self-efficacy and our self-concept and our self-empathy. Whereas if we are given an avoidance goal, we tend to actually have, it negatively affects our self-efficacy. The participation in avoiding something is not as psychologically healthy as it is to strive toward a goal. And we kind of intrinsically know that, right? Like we want to work in a workplace where people are giving us, say, hey team, let's go for this. Like not where someone's kind of shushing us and don'ting us all the time, right? Like that does not sound like a psychologically healthy workplace. And some of these worthy approach goals are things like, yeah, let's increase the civility in our workplace. Let's increase the respect in our workplace. Let's increase the engagement in our workplace or the psychological safety. And in fact, we actually have very, very good, well-conducted waitlist controlled studies where people came up with interventions to do exactly this, and they worked. They had like remarkable effects. So again, I don't want to bore you with them too much, but basically the U.S. Veterans Health Administration still has a very large program for this called CREW, Civility, Respect, Engagement in the Workplace, where they put people together and they kind of say, hey, let's interact in order to achieve this approach goal of increasing civility, respect, and engagement in our workplace. And that was tested out by Heather Laffinger and Michael Leiter in a selection of Canadian workplaces to see whether it was actually generalizable into a different context. So they repeated it in hospitals in Nova Scotia and Ontario, and they found that not only did it succeed, but it had a lasting effect. When they measured people's burnout levels 3 years after the intervention, their burnout levels were lower if they had participated in the intervention. And it had all kinds of knock-on effects, like by decreasing absenteeism and increasing productivity. So it was sort of like, duh, why aren't we doing this? But suffice it to say that today we're not. We're actually still trying to blame and shame people for their disruptive behavior. And so finally, I guess the other thing that I wanted to sort of throw in the mix is that in medicine anyway, and a little bit perhaps less in the research realm, but definitely in the practice realm, we perceive our job is to find the bad parts and cut them out or remedy them, right? Like our whole idea of our whole paradigm of diagnosis and treatment, the way that we make people better and that we make the world better is by finding the problems and solving them. And there are other ways to aspire to improve the world around us. And so if you've never heard of appreciative inquiry, I would encourage you to kind of read up on it, because it's basically a different paradigm for how we make the world a better place. And it sort of says, well, instead of trying to find all the problems, let's look for the things that are working well and make them bigger. Let's say, well, if this is working well here, could we expand the sphere of influence of that sort of nexus of goodness? And so I think that these are the kinds of things that we need to ask ourselves when we're talking about psychological safety, because unlike biological and physical and chemical hazards, we are the things that are affected by this stuff. Right? It's us and our interpretation of our social universe that is really what is at stake. Okay, so in summary, hazard elimination, I don't want you to walk away from this thinking that we should abandon the hierarchy of control, and that because I think it really does work well in the biological, chemical, and physical realms. But I don't think it has, I think if you try to extend it or generalize it into the psychological realm, it has unintended consequences. And the struggle to improve the quality of healthcare may be one of the unintended consequences. We haven't really been able to make the quality improvement that we want to in healthcare the same way that we have been able to get on board with a transformative thing that has actually positively affected worker safety in other ways. And the new policy approaches that we might need to think about is adopting Edmondson's definition of psychological safety instead of the CSA one, and framing this as an approach goal, which it kind of already is, and then using CREW and other appreciative inquiry interventions to achieve that goal. So that is it. How am I doing for time? So we have lots of time for questions, I think. So. Yeah, so good. Just in case it's not transmitting to the people online, so the question was, what is this was the CSA standard approach of using the hierarchy of control to classify psychological hazards, was that a necessary step in the evolution? I don't know. That's a really, really good question, though. I think that the CSA standard could have been better. Like it could have. Here's what I notice about, like, in a lot of hospitals we have interpersonal conduct policies, right? And what I think is good about having a conduct policy is that it makes it clear that it's really important how we think we are being treated in our work context, right? So it says that it's actually not okay for people to walk around feeling like they have been mistreated in their and if that's happening to you, we want to hear about it. It's not like, so it's kind of dispelling the suck it up mentality. So that is an important thing that I think policies can do, and it may be something that the CSA standard did by saying, we think that organizations should measure the psychological health and safety somehow, and they should make a commitment to improving it. Like, I could get on board with that, and so that part of it I think is good. The part where I really lose it is when they actually try to take an approach like the hierarchy of control and just apply it, because we've had other things where this has kind of gone wrong. Like the same thing kind of happened when we started to try to enumerate psychological demands the same way that we enumerate physical demands. It doesn't really work as well, and in some cases I think it gets in our way. Big question though.
work environment work and health, particularly like more things. So I think when you can lead to an expecting here that when you approach it different, you are if you agree with me, then you can how do you start to do that?
Yeah, more safe. Yeah. Well, you know, in a lot of contexts, work is psychologically more safe because now, partly because of labor market dynamics, right? Like now we're entering the era of labor shortage. And so people are worried about, is my workplace attractive enough to scarce workers? And so it's sort of like, oh, market forces have changed it around in a lot of contexts, except for in healthcare, right? Like it's interesting that we still struggle with this in healthcare for some reason. And so Google, I don't know if you heard that, what is it? They did this project, it's not Aphrodite but it's a Greek name. They basically wanted to figure out what makes, we have high performing work groups in Google and low performing work groups in Google. And we want to know what is the difference between them. Well, they actually did think that the one thing they could measure was psychological safety. Psychological safety high in high performing work groups in Google, low in others. And there's a New York Times article somewhere in the last year or so that talks about that. But then they started talking about, well, what intervention could we do to take a low psychological safety workplace and move it? That's where things get very, very complicated. And they couldn't arrive at anything really concrete. The one thing they did, and it's like a weak effect, it's not a huge effect size, but they found that taking steps to equalize people's participation. So in other words, when you have a meeting like this, instead of asking people for questions, I would go around and go, what's your comment? What's your comment? What's your comment? What's your comment? You don't have one? You can pass. Right? So in other words, equalizing the opportunity for inclusion and taking discrete steps to do that was the only thing that actually had sort of a measurable effect on psychological safety. But I think I agree with you in that, yeah, this isn't the whole picture. And I will say for sure that the people who wrote the CSA standard didn't intend it to go to a place where the hazards were identified as individual workers, right? But that is what happened. And so it wasn't their intention for sure. They thought that, we're leading ourselves towards, psychologically healthy and safe workplaces. But it's an unintended consequence of that is that when people think about what are the psychological hazards in my workplace, they are people. That's who it is. And it's a who, not a what. So I think we're sort of saying the same thing. Yes. Yeah. Right. Well, that's a good, wow, there's so many layers to that. Just as an aside, one interesting thing that people may not know, but one of the work rules in a flight crew is that you are not allowed to call each other by anything other than your first name. So the pilots must refer to each other as, Tom and Sue, not Mr. So-and-so and Ms. So-and-so. Everybody has to call each other by their first name. And that was implemented because they found out, they actually did like a voice recorder study that showed that errors were much more likely to happen in flight crews where they did not identify each other, but where there was a perceived power imbalance. But so, power imbalances, well, physicians, I would say that physicians and surgeons they're in a weird place in a lot of workplaces because they're not employees, right? So they're integral, but they're outsiders, and they view it as their responsibility to shake things up. Where I'm sure everybody's been following the Jeff Bezos and the National Enquirer thing, and I admire the guys. Like, if I can't stand up for this and resist this, then who can? And I think that that's kind of the heroic attitude that a lot of physicians will adopt, and then what happens is their intention is good. Their interpersonal skills are probably low because it wasn't until Kenneth's 2005 that interpersonal skills were even in the equation. So they weren't, we're still, the medical workplace is still populated by people who didn't actually, that was never put up as a goal for them. Now it is, but, so they're struggling because they used to just be able to share their ideas and people would pay attention, and now it's like, no, that's not how it works. And so their response to that is, oh, what, I didn't say it loud enough? Or now you're really frustrating me and I'm going to shout at you. And then it's like, okay, game over. Now you're really disruptive. And we've just been waiting around to label you, and now we have a formal mechanism to do it. And that's kind of how it sort of evolved. And so so the final layer of your question was, how do we get by and even have this conversation? It's because we had enough physicians and surgeons who were labeled as that when we raised our hand to say, hey, this is an important conversation we should have, we had lots of buy-in because many people who are members of Doctors of BC had that experience of being labeled as the psychological hazard in their workplace.
I'm just reflecting on your answers here. It seems to me that there's a theme that really is talking about, sort of having a horizontal thinking about how we actually
Yeah, well, that's, I think that's actually one of the things that was intrinsic to the sort of, Kaizen methods and all the Toyota production system. Like, that's, the flattening of hierarchies has been going on in workplaces since the 80s, partially as a result of the TQM. And but in the healthcare workplace, like, this is part of the problem that physicians have when they get together in groups, is that all of their training, even through residency, there was always a supervisor to whom you could appeal to have a dispute settled. And then suddenly, when you graduate and you're finished, you're in a peer culture where there's nobody, right? And so, that it gets very tricky and you've got to grow up really fast, but you don't actually have the skills that you might have acquired in business school or something, right? You don't recognize that settling disputes with colleagues is an intrinsic part of your job. And suddenly you're being asked to do it all the time, and you really feel kind of empty because it's like, well, can't I just go take out somebody's appendix or something? I really don't know how to do this part. But so it's quite unsettling to be in a peer culture, but I think peer cultures are actually are becoming more and more prevalent. I mean, the gig economy and all that stuff. The doing of work is so much more of a peer culture now. And in some cases, what we're seeing is that the dispute settlement mechanism is Twitter, which leaves us asking questions about, how do we elect presidents and stuff. Yeah. Yeah.
I think it is very much function of the context in which you implement. So we've got community, hospitals that you talked about. How big was their size? By that, I'm not trying to trick you, I'm just wondering if you implement that, you don't need to have a smaller threshold open because you can see how much money you can make. Because TQL,
Right.
Right.
Right. So if I left people with the impression that there was only 2 hospitals in Canada, that is in error. I think it was 17 in 2 provinces. So Nova Scotia and Ontario, and they were a variety of sizes. And in some cases, it's not really a hospital-wide initiative. It's actually a departmental initiative. So it's implemented at the work group level, and the hospital more or less consents to have its work groups participate. But CREW is fundamentally an idea. The idea behind CREW is that you need to set aside time to spend with the people that you work with to talk about nothing but your relationship, right? All tasks are put aside. We are talking here about the relationship that we want to have as colleagues. And that is a very tough thing to do in the healthcare workplace because there's always patients waiting to see you or patients waiting for your attention. So to have somebody give you permission to do no tasks, no patients are doing, this is you guys talking amongst yourselves about your relationship. And they implemented it. So even though there was, I think, 17 hospitals, there was many, many more work groups, and it was a waitlist controlled. So there was, like this hospital's going, and basically everybody can sign up, but so half of them would be randomized at the time of sign up to sort of being you're going first or you're going second, and they would have so that's how they got the comparison groups. It still does suffer a little bit from volunteer bias because nobody was forced to go through it, right? And that, I think, in some cases where you're kind of like, we would like to know what happens when you do force people, but because it's always the last groups to sign up are the ones who most need it, right? So it's a good study. You should read it. It's the long stuff. That's the short of it. Okay.
The insured territory, but I was just wondering how your feeling. How does this apply to other workplaces, not necessarily only hospitals?
In healthcare, yeah. Well, it's been a while since I've been in the shop for 11 years now, so it feels like it's funny how fast memories fade. But I mean, I used to be dealing with, I worked for GlaxoSmithKline and Atomic Energy Canada and Ontario Hydro, workplaces like that where there were nothing like this. Because you do have this hierarchical authority to make things happen, or in some cases, a bipartisan thing where there's a health and safety committee that's got union and management representation. So there's different ways of making things happen in healthcare. Healthcare seems like almost the most complicated or complex workplace to get things done because it's adaptive at so many levels. Amy Edmondson wrote an article in 2016, which I had in a previous version of this slide set that took out because I couldn't figure out why it was there. But but it's comparing psychological safety and its measurement and its consequences in healthcare and education. So education being another key one that is a little bit complex because teachers and in various places teachers sort of function a little bit like doctors, and so it's again worth a read. Construction, yes, again, so many freelancers and all that kind of stuff, and I feel like I have a zero handle on construction as a sector because I've never worked in that. We've exhausted the questions. No. Well, if it's a really smaller group, I would do that, but we're out of time. Thank you. Thank you very much. I'm very grateful for your time and attention, and I wish you all a very healthy and safe long weekend.